Hi everyone. Today we will discuss about hemodynamics and resuscitation in pulmonary embolism. Welcome to ER Sono. All the information in this presentation is gathered from various journals, textbooks, websites and blogs. This is an honest attempt to learn by teaching few difficult concepts. I appreciate any feedback to improve future sessions. Let's begin by looking at two cases. A 56-year-old male presenting with shortness of breath and chest discomfort for 1 day. His heart rate is 132, blood pressure 80/56, saturating at 86% on room air, and his cap refill is 5 seconds. His ECG showed sinus tachycardia with RV strain, and the CTPA showing bilateral PE with RV strain. How do we manage this patient? In case 2, we have a 56-year-old male presenting with shortness of breath and chest discomfort for 1 day. His heart rate is 100 per minute, blood pressure is 110/76, saturating at 92% on room air, and his cap refill is 2 seconds. His ECG showing sinus tachycardia with RV strain, and his CTPA showed bilateral PE with RV strain. How do we manage this patient? And how does this management differ from the patient in our case 1? So this brings us to very important questions. What happens after we diagnose a pulmonary embolism? Should we give heparin and refer to a specialty? Does it end there? How do we resuscitate unwell patients with pulmonary embolism? What is the cause of death in pulmonary embolism? And how do we assess the severity of pulmonary embolism? In relation to management of pulmonary embolism, we should be clear about few basic concepts. Massive PE. Massive PE is characterized by systemic hypotension, which is a systolic blood pressure less than 90 mm mercury, or drop in systolic pressure of at least 40 mm mercury for at least 15 minutes, which is not caused by a new onset arrhythmia, or shock evidenced by tissue hypoperfusion, hypoxia, altered consciousness, oliguria, or cool, clammy extremities. Submassive PE. Submassive PE is characterized by a subgroup of patients with non-massive PE who are hemodynamically stable but have right ventricular dysfunction or hypokinesis, which is confirmed by echocardiography. Why do we need to differentiate these two conditions? The prognosis and management is different in massive PE and submassive PE. The spectrum includes massive pulmonary embolism, submassive pulmonary embolism, and a pulmonary embolism without hypotension and normal right ventricle. The following is a table from a study showing how the individual variables cause mortality in a patient with pulmonary embolism. RV dysfunction with no hypotension. If you look at the table, RV dysfunction alone with no features of hypotension or shock increases mortality by 8.1%. Presence of hypotension increases mortality by 15.2%, and cardiogenic shock increases it to 24.5%. Mortality in patients who receive CPR was 64. Right ventricular dysfunction. Right ventricular dysfunction is characterized qualitatively as mild, moderate, or severe based on the degree of hypokinesis, and quantitatively based on the RV dilatation with RV to LV end diastolic diameter ratio greater than 1. Remember, normal RV should be 2/3 the size of left ventricle. RV end diastolic diameter greater than 30 mm. A paradoxical septal systolic motion characterized by septal movement towards right ventricle in mid-systole. I will discuss this in detail later. Pulmonary hypertension with a pulmonary artery systolic pressure greater than 30 mm mercury and a TR velocity greater than 2.8 meters per second. Absence of RV wall hypertrophy, which means the free wall thickness greater than 7 mm. Calculating TR velocity and pulmonary artery systolic pressure is for advanced echocardiography uses, but the other signs can be identified on bedside echo. McConnell described a finding suggestive of RV dysfunction due to PE. It has low sensitivity but high specificity. In other words, you won't see this sign in all cases of PE, but presence of this sign is highly suggestive of PE. It is described as akinesia of RV free wall with sparing of RV apex. Here is a demonstration of McConnell sign. You can see akinesia of RV free wall, but the apex is spared. Surrogate markers of RV dysfunction. The surrogate markers for RV dysfunction include physical exam with elevated JVP, tachycardia, parasternal heave, loud P2, tender enlarged liver. But none of these are specific or sensitive when used alone. ECG. Sinus tachycardia, supraventricular tachyarrhythmias, S1Q3T3, new complete or incomplete right bundle branch block, P pulmonale, ST elevation in anterior leads, T inversions in V1 to V4, troponin, BNP, and heart type fatty acid binding protein, which is a biomarker for myocardial injury. Why is troponin elevated in PE and what is its significance? Elevated pulmonary artery pressures causes increase in RV wall tension, which in turn increases right ventricular oxygen demand and reduce the perfusion of right coronary artery. Elevated troponin levels is a risk factor for poor outcome in acute PE and correlates with ECG and echo findings of RV strain. It is also associated with increase in overall mortality and complicated in-hospital course, like requiring inotropic support, escalation of therapy with thrombolytics, CPR, and mechanical ventilation. Right ventricular coronary perfusion pressure is the difference between mean arterial pressure and RV end diastolic pressure. Systemic hypotension as well as elevated RV end diastolic pressure may reduce RV coronary perfusion pressure and myocardial blood flow, resulting in RV ischemia, which is identified by elevated troponin, CKMB, and even RV infarction during autopsy. BNP. The magnitude of BNP elevation has been shown to predict adverse outcomes, that is, higher the BNP, higher the adverse outcomes. This is the result of a study showing negative predictive value of 93% for major clinical events in patients with a BNP of less than 90. Combination of troponin and NT-proBNP is better for risk stratification of patients with PE in acute setting. Let's look at the pathophysiology of hypotension in PE. Acute right ventricular outflow obstruction leads to RV pressure and volume overload, which results in LV failure by two mechanisms. Right ventricular outflow tract obstruction leads to reduction in left ventricular preload, which means less blood pumped by RV due to obstruction and less blood reaches left ventricle. Right ventricular end diastolic pressures are elevated, which causes the interventricular septum to bulge into LV cavity and impairs LV filling. This is also known as diastolic interventricular dependence. The end result is decrease in cardiac output and hypotension. Look at this illustration. In parasternal short axis view at mid-papillary level, the left ventricle appears circular in cross-section, whereas RV is seen as thin-walled crescent. The interventricular septum is seen between the two. Normally, the interventricular septum contracts together with other walls of the LV. This is how a normal systole and diastole looks like. When there is a pressure overload of right ventricle, septal flattening occurs in the end systole. We should also remember that as RV pressure is increased, RV ejection time is prolonged. In volume overload, like in severe tricuspid regurgitation or aggressive volume resuscitation or decompensated heart failure, the LV septal flattening occurs in end diastole. Eccentricity index can be measured by dividing D2 by D1. This picture demonstrates the physiology in pulmonary embolism with both pressure and volume overload. D-shaped septum is seen in end diastole, impairs left ventricular filling. In mid-systole, the septum moves outwards towards right ventricle and doesn't move together with the rest of the LV walls. Whereas in mid-diastole, the septum moves inwards while the rest of the walls are moving outwards. This is the paradoxical septal movement. Here is an ultrasound video clip showing paradoxical septal motion. Early diagnosis is the key in management of PE. The interval from onset of symptoms to death is relatively short. In massive PE, 50% die within 30 minutes, 85% die within 6 hours of onset of symptoms. What is the cause of death in pulmonary embolism? Is it hypoxia, hypercarbia or circulatory collapse? Correct. It's the circulatory collapse. Let's talk about resuscitation of a patient with PE. Please note, we are only discussing about massive and submassive PEs here. Oxygen. Avoid hypoxia and hypercarbia. Both of these can result in pulmonary vasoconstriction and increase right ventricular afterload. High flow nasal cannula is a good option for patients with poor oxygenation or having excessive work of breathing. It also reduces physiological dead space. Intubation. Avoid intubation if possible, as hypoxia, hypercapnia, positive pressure ventilation, and sedation may all compromise patient's hemodynamics. If patient is for thrombolysis, try to delay intubation and prioritize thrombolysis. If intubation can't be avoided, initiate vasopressors first. Intravenous fluids. There are no human studies regarding hemodynamics in crashing patients with massive PE. It's very tempting to start a liter of IV fluids in undifferentiated shock, but this can worsen the hypotension further. Depending on where you are on Frank-Starling curve, a certain amount of central venous pressure elevation with IV fluids may improve RV filling and cardiac output. As explained in the pathophysiology earlier, excessive CVP elevation will over-distend the right ventricle, causing diastolic compression of left ventricle and reduce cardiac output. In this picture, you can see the D-shaped septum causing impaired LV filling. Here's a study showing increase in cardiac index after an infusion of 500 ml of dextran 40 in patients with acute PE. But in this study, the sample size is small and all of the patients were normotensive. An improvement in cardiac index was inversely related to baseline RV end diastolic volume. That is, patients with RV strain did not improve their cardiac index as well as those without any RV strain. Here's another study showing the diuretics improved outcome compared to volume expansion. Available evidence suggests patients with acute PE and severe RV dilatation probably are not benefited from volume loading. They actually improve with volume removal. Rarely patients will have combination of hypovolemia and acute PE. Identification of hypovolemia is crucial based on history, clinical exam, bedside ultrasound. They respond well to volume administration. One best way to assess this is by passive leg raise, tilting head down. Look for any improvement in mean arterial pressure or any clinical deterioration. Volume administration should be in small boluses and should be stopped after correcting hypovolemia or if patient deteriorates with fluids. Get early and frequent echo. Vasopressors. Early vasopressors to counteract hypotension and hypoperfusion of right ventricle. Remember, time is muscle. Options include noradrenaline, high-dose dopamine, phenylephrine. Norepinephrine causes alpha-mediated vasoconstriction, leading to increase in mean arterial pressure, which in turn increases right ventricular coronary perfusion pressure. Beta-1 mediated inotropic effect improves right ventricular function. It has minimal effect on pulmonary vascular pressures. Adrenaline has stronger inotropic activity and also causes pulmonary vasodilation due to beta-2 agonism. The choice of vasopressors is probably less important than overall strategy of starting early vasopressors. Inotropes. Dobutamine, milrinone can be used to enhance RV function and cardiac output. They also reduce pulmonary vascular resistance by different mechanisms. These drugs are potent vasodilators and can cause significant systemic hypotension. Therefore, inotropes can be used in conjunction with vasopressors to prevent this. To summarize, in a hypotensive patient with decreased cardiac output, start vasopressors and inotropes can be added later if cardiac output remains low. In a normotensive patient with evidence of decreased cardiac output, inotropes can be started first, then vasopressors can be added if hypotension develops. Do not delay thrombolysis to insert central line. Start peripheral vasopressors. Vasodilators. Vasodilators are used to reduce right ventricular afterload. They have more profound systemic vasodilatory effect, leading to decrease in SVR and worsening RV ischemia. Prostacyclin is a pulmonary vasodilator, but has a possible risk of worsening ventilation perfusion mismatch or increasing pulmonary capillary wedge pressure in patients with concurrent LV dysfunction. Inhaled nitric oxide. Inhaled nitric oxide is useful in managing right ventricular failure and decreasing pulmonary vascular resistance without reducing systemic pressures. Inhaled nitric oxide increases perfusion only to areas that are ventilated, therefore improves VQ mismatch. It also improves right-sided cardiac output by reducing the afterload and therefore enhances the efficacy of inotropes. Learning point. If cardiac output remains low despite vasopressors and inotropes, a pulmonary vasodilated trial with inhaled nitric oxide may be beneficial when pulmonary hypertension is present. Thrombolysis. The only intervention to improve mortality in massive PE. Pursue thrombolysis early, because if a patient with pulmonary embolism develops progressively worsening vital signs, this may signal impending arrest. Half-dose TPA is equally efficacious as full dose with a better safety profile. However, thrombolysis is controversial in submassive PE. Possible benefits of thrombolysis include improvement in lung perfusion and prevention of long-term pulmonary artery hypertension. The complications include intracranial hemorrhage. Consider half dose to minimize complications. Need more studies to show mortality benefit over complications. Anticoagulation. Avoid anticoagulation if planning to thrombolize. Bad outcomes occur when anticoagulation and thrombolysis are given together. Withhold anticoagulation for 2 to 3 hours until after thrombolysis, and also give reduced dose. Surgical catheter embolectomy needs large setup and experienced personnel. Increased ITU stay. It's also expensive. Indicated in patients with high risk of intracranial hemorrhage or failed thrombolysis. IVC filter. IVC filter is used to prevent recurrent pulmonary embolism. It is indicated when patient can't be anticoagulated. ECMO. ECMO is potentially life-saving therapeutic option by providing hemodynamic and respiratory support in patients with acute high-risk PE. VA ECMO is used as a treatment for shock from PE, a bridge to catheter directed lysis or surgical thrombectomy. Cardiac arrest in PE. Survival rate can be improved with aggressive CPR and prompt thrombolysis. Know the dose of thrombolytics in your institution. Altiplase 50 mg is a good start. Repeat death phenomenon can occur with PE, where a patient receives a bolus of epinephrine, gets ROSC for a few minutes, lose their pulse, get another bolus of epinephrine, regain pulse for a few minutes, then lose it again. Therefore, when ROSC occurs, monitor pulse carefully and anticipate it may be short-lived. Consider starting a norepinephrine or epinephrine drip early. Supraglottic airway device is good enough if you are able to oxygenate and ventilate. Do not interrupt CPR to intubate. Summary. The take-home points are caution with IV fluids, early vasopressors plus or minus inotropes. The only evidence-based intervention that seemed to improve mortality in massive PE is thrombolysis. Intubation can be hazardous and should be avoided if possible. Patients die from cardiovascular collapse and intubation may worsen this. Thank you.